when a patient walks into your clinic with a bright red, irritated eye, your first instinct as a clinician is probably to treat it like a really simple fix.
Oh, absolutely. It looks like a completely straightforward symptom.
Right. But in veterinary ophthalmology, canine conjunctivitis is basically a masterclass in deception.
It really is. Treating a red eye without understanding the underlying mechanism is, well, it's a guaranteed path to clinical failure.
Yeah, I like to compare diagnosing a red eye to walking into your kitchen and finding a massive puddle of water on the floor.
Right, your brain immediately goes, oh, someone spilled a glass of water.
Exactly. You assume that's the primary cause, right?
Right.
The water's the only problem. But in reality, if you just look up, the roof is leaking.
And that puddle is just a symptom of a much larger, systemic or structural failure.
Which is exactly what we're tackling today. We want to help you, the vet student, whether you're prepping for board exams or like getting ready for clinical rotations, we want to help you master this.
Yeah, we're doing a deep dive into the pathophysiology, and this is so important, the incredibly strict diagnostic order of operations.
Oh yeah, so strict. And the exact treatment protocol, so you never get fooled by that leaky roof.
Right. And before we even look at the pathology, we really have to ground ourselves in the anatomy.
Okay, so we're looking at the conjunctiva.
Exactly, which our clinical guide defines as the highly vascularized mucous membrane covering the anterior portion of the sclera.
So the white of the eye.
Yes, the white of the eye. And it also lines both the inner eyelids and the posterior surface of the third eyelid.
It's just this continuous, incredibly sensitive tissue bed.
And it reacts to absolutely everything.
It really does. So if we stick with the puddle analogy, I mean, primary causes for that red eye do exist, right?
Sure, yeah. They can be allergic, especially in atopic dogs where their immune system is just hyper-reactive to, environmental pollens or dust.
Or they can be purely environmental, like, I don't know, foxtail seed physically stuck under the eyelid.
Oh, those are the worst. Or even irritation from heavy smoke. But the most critical takeaway for you guys studying this data is that primary bacterial conjunctivitis is incredibly rare.
Meaning bacteria as the root, solitary cause of the infection.
Yeah. It's almost non-existent as a standalone issue, which completely defies human medical instinct.
Right, because in humans, pink eye is usually just a bacterial infection you catch from someone else.
Exactly. But in dogs, when you see a patient with thick, yellow, mucopurulent discharge, it is almost always a secondary bacterial infection.
The bacteria are just opportunistic.
Right, they're just taking advantage of a compromised environment. And the absolute most common driver of that compromised environment is keratoconjunctivitis sicca.
Right, KCS. Good old dry eye.
Because tears aren't just water, they're like the eye's primary defense mechanism.
Right, and KCS happens in two main ways, right?
Yeah, so you can have an aqueous tear deficiency where the lacrimal glands simply aren't producing enough fluid volume to wash away debris and bacteria.
Okay, and the other way.
You can have a qualitative tear deficiency. That means the sheer volume of tears is fine, but the tears lack the necessary lipid or mucin layers.
Oh, wow. So without the lipid layer, the tears just evaporate too quickly.
Exactly. And without the mucin layer, the tears literally can't stick to the corneal surface.
So in either scenario, the eye just dries out, friction increases, and the normal, healthy bacteria on the eye suddenly multiply out of control.
Yep, and cause an infection. The bacterial overgrowth is just the puddle. The KCS is the leaking roof.
That makes so much sense. And it's not just a lack of tears causing friction, right? You have structural issues that basically assault that mucous membrane.
Oh, absolutely. You've got entropion, where the eyelid physically rolls inward.
Ugh, just dragging fur across the cornea with every blink.
Yeah, it's awful. Or you have ectopic cilia, which is just a structural nightmare.
Wait, that's where an abnormal eyelash actually grows straight through the conjunctiva, right?
Yes. And it scrapes against the eye with every single blink, like a jagged windshield wiper.
Ouch. So the red eye is quite literally the conjunctiva just screaming for help.
Exactly. The mechanical irritants are super common, but the infectious agents that actually can act as primary triggers are vast.
Right, because if bacterial causes are rare, viral and parasitic causes definitely are not.
No, not at all. We have a whole viral alphabet soup that targets ocular tissues, like canine herpes virus 1, or CHV1.
And canine distemper virus, CDV.
Yep, and canine adenovirus 2, CAV2.
Which honestly makes sense because distemper and adenovirus are, systemic infections,
Right, they affect the respiratory tract, the GI tract, and the mucosal linings.
including the conjunctiva. The eye isn't somehow magically isolated from the rest of the body's viral load.
Exactly. The virus invades the epithelial cells of the conjunctiva, causing intense inflammation. And we see similar intense reactions with parasites.
Oh, the parasites. The clinical guide specifically highlights leishmania, right?
Yeah, which is a protozoan that can cause severe granulomatous inflammation in those ocular tissues.
And then there's onchocerca, a nematode that can migrate right through the connective tissue.
And of course, thalassia.
Okay, thalassia is literal nightmare fuel.
It really is.
I mean, it's an actual eye worm that lives in the conjunctival sac and the tear ducts.
Yeah, the red eye in that case is quite literally the body's reaction to worms physically swimming across the surface of the eye.
Ugh, it's such a stark visual. But I guess it highlights why a really thorough exam is so necessary.
Definitely. Because when these patients present, regardless of the underlying cause, you are going to see a classic cluster of clinical signs.
Like blepharospasm.
Right, which is that severe, painful squinting and squeezing of the eyelids.
And you'll see conjunctival hyperemia, which is that bright red blood vessel engorgement.
Yeah, and chemosis.
Let me stop you there. Chemosis is severe tissue edema, right?
Yes, exactly. The conjunctiva gets so swollen with inflammatory fluid that it looks like this clear, gelatinous blister just bulging out around the cornea.
The tissue literally balloons outward.
It does. You'll also see discharge, obviously, varying from clear and serous to thick and mucopurulent.
And the text says you need to look really closely for follicle formation, specifically on that posterior surface of the third eyelid.
Yes, they look like tiny, translucent cobblestones. They're basically hyperplastic lymphoid follicles.
So like miniature lymph nodes reacting to chronic antigenic stimulation.
Exactly. And this is incredibly common in young dogs, usually under 18 months old, whose immune systems are overreacting to environmental allergens.
Which brings up a really important point about genetics. The guide makes it super clear that certain breeds are walking into your clinic with a heavy predisposition for specific conjunctival issues.
Oh, absolutely. German Shepherds are the classic example.
Right, they are highly predisposed to lymphocytic plasmacytic conjunctivitis.
Yeah, often accompanied by chronic superficial keratitis, or penis. The German Shepherd's immune system essentially misidentifies its own ocular tissue as foreign.
So it leads to this aggressive infiltration of lymphocytes and plasma cells.
Right. It's a chronic, systemic autoimmune flaw that just happens to manifest on the surface of the eye.
But if we're talking about breed-specific pathology, young female Dobermans present with perhaps the most bizarre condition in the whole text.
Oh, ligneous conjunctivitis.
Yes. If you actually look at the pathology of this, it's wild. The disease process creates this thick, amorphous, eosinophilic hyaline-like material.
Right, so in plain terms, instead of normal inflammatory swelling, their conjunctiva produces this bizarre, opaque, woody, fibrous buildup.
It literally turns the soft mucous membrane into a rigid board-like structure.
It is a striking and thankfully incredibly rare pathology finding.
But okay, to ever get to the point of diagnosing something like ligneous conjunctivitis or finding a thalassia worm, you have to survive the clinical workup.
That is the tricky part.
Because if a red eye is just a symptom of a dozen different invisible causes, how do you safely figure out which one it is without accidentally, making the eye worse?
This is exactly where the diagnostic order of operations comes in.
Right. And I really want to put myself in the shoes of our vet student listeners here.
Okay, go for it.
If a dog comes into my clinic and its eyes are just completely caked in massive amounts of thick, green, mucopurulent discharge, my very first instinct is to immediately grab a swab to culture that bacteria.
Which is a totally normal impulse.
Right? Or like grab a bottle of sterile saline and flush all that gross material out so I can actually see the eyeball. But according to this guide, doing that is a massive clinical error.
A huge error, because if you flush that eye or take that swab first, you've just ruined the most critical diagnostic test you have.
The golden rule.
Yes. The golden rule of ophthalmic diagnostics is that the Schirmer tear test must be performed before absolutely anything is placed in the eye.
So no flushes, no topical anesthetics, no diagnostic stains, nothing.
Nothing. Zero. The Schirmer tear test uses a small strip of specialized paper placed inside the lower eyelid to measure aqueous tear production over 1 minute.
And remember, KCS is the main driver of those secondary bacterial infections.
Exactly. So if you flush the eye, you're leaving residual fluid behind.
And if you add anesthetic drops,
You're artificially increasing the fluid volume and potentially altering the eye's basal tear reflex.
so in both cases, your Schirmer tear test will read artificially high. You'll miss the KCS diagnosis entirely, and the dog just continues to suffer.
Spot on.
Okay, so the tear test is step one, but what about that culture?
Right. If you've ruled out KCS and you want to send a swab out for an aerobic bacterial culture and sensitivity because that discharge is just so severe, when does that happen?
Yeah, when do I swab it?
The swab for CNS must happen immediately after the Schirmer tear test, but still before any drops, stains, or flushes touch the eye.
Why is that?
Well, topical anesthetics and diagnostic stains contain preservatives and chemicals. If those chemicals get onto your swab, they cause inhibition or dilution of bacterial growth in the lab.
Oh, wow. So the lab will tell you the culture is negative, but in reality, your anesthetic drop just killed the sample in transit.
Exactly. So the strict sequence is Schirmer tear test first to measure the tears, swab for culture second to capture fewer bacteria.
Then and only then can you start putting drops and stains into the eye to look around.
You got it. And when you finally do look around, the first thing you have to determine is whether the redness is actually conjunctivitis or something much more dangerous deep inside the eye.
This is where visual observation is just critical. You have to distinguish conjunctival hyperemia from episcleral vascular congestion.
Right. Conjunctival hyperemia involves the superficial branching blood vessels right on the surface.
So if you gently touch the conjunctiva with a sterile cotton swab and move the tissue, those superficial vessels will just move right along with it.
Exactly. But if the vessels are deeper, darker, straighter, and they do not move when you manipulate that surface tissue,
Then you're looking at episcleral vascular congestion,
yes. That lack of mobility means the engorgement is happening deep within the sclera.
which points directly to severe intraocular disease like glaucoma or anterior uveitis.
It is a massive red flag. It tells you that you're dealing with a vision-threatening emergency, not just some surface inflammation.
That cotton swab mobility test is such a simple but vital visual clue. Immobile, deep vessels equal internal danger.
Always.
Okay, so once you've checked the vessels and taken intraocular pressures to rule out glaucoma, it's time for the fluorescein stain.
Right. The fluorescein dye is highly water-soluble, and it binds specifically to the deeper layers of the cornea, the stroma, if the protective outer epithelium is damaged.
So if you apply the stain, flush it out, and there is no bright green retention on the eye, you have successfully ruled out an ulcerative keratitis.
Or a corneal ulcer, yeah.
But the stain also acts as like a tracking dye for the ocular plumbing, right?
It does. You put the stain in the eye, and you wait to see if it flows out through the nose.
If the dog's nose suddenly glows green, it rules out nasolacrimal disease. The duct is totally open.
But if it doesn't pass?
Then you have a blockage in the outflow system.
Exactly. And a nasolacrimal duct flush is required to clear whatever debris or inflammatory material is plugging the drain.
Okay, so we've done the tear test, cultured the bacteria, checked the vessels, and stained for ulcers and plumbing issues. Now we need to look at the cells themselves.
Right, cytology. Doing a conjunctival scraping isn't always going to give you a definitive cause, but if you look under the microscope, the cells present act like a fingerprint for the type of inflammation.
Okay, let's test this. If I look at a slide and it is absolutely packed with eosinophils, my mind immediately jumps to an allergic response.
Because
Eosinophils are the white blood cells that specifically deploy to fight allergens.
that's a solid deduction. Eosinophils strongly point to allergic conjunctivitis.
Okay, conversely, if you're looking at predominantly lymphocytes and plasma cells,
You're looking at the chronic immune-mediated response, which is typical of lymphocytic plasmacytic conjunctivitis.
got it. What if I'm looking at neutrophils, but they're degenerate? Like they're swollen, the nuclei are breaking down, and I can actually see bacteria trapped inside their cytoplasm.
Well, that means the neutrophils are actively engaged in a losing battle at the site of infection. Degenerate neutrophils with intracytoplasmic bacteria confirm a true active bacterial infection.
But then you have intracytoplasmic inclusion bodies. That means the pathogen is literally hiding inside the epithelial cells themselves, right?
Yes, and that specific intracellular presentation points directly to chlamydial or mycoplasmal infections. It's a very specific cellular signature.
Okay, so you've navigated the gauntlet, you ran the tests in the correct order, you scraped the cells, and you found the real reason the eye is red. Now you have to build a treatment plan.
Which is where things get really complicated.
Because diagnosing the dog is only half the battle, right? The other half is training the human attached to the dog.
Client compliance is basically the weak link in veterinary ophthalmology. You can prescribe the absolute perfect medication, but if the owner administers it incorrectly, the whole treatment fails.
I always compare client education for eye medications to teaching someone a strict multi-step skincare routine.
Oh, that's a good analogy.
Right. If you give someone a water-based serum and a heavy, thick moisturizer, but they put the moisturizer on their face first, that water-based serum is never going to penetrate the skin.
It just sits on top.
Exactly.
Yeah,
The order dictates the efficacy, and eye meds are exactly the same.
because the physics are exactly the same. Ointments create a lipid barrier on the surface of the eye. If you prescribe both a liquid solution, so drops, and an ointment, the client absolutely must use the solution first.
If they apply the ointment first, the drops will just hit that lipid barrier and roll right down the dog's face.
Yep. And you have to wait between layers. The guide specifies waiting at least 5 minutes between treatments so the eye can actually absorb the first drug before the second one is introduced.
And just like washing your face before applying skincare, you have to clean the eye.
Obviously.
If there is copious mucopurulent discharge, the owner must gently flush or wipe it away before medicating. You cannot drop an expensive antibiotic onto a millimeter-thick layer of dead cells and mucus and expect it to reach the conjunctiva.
The medication has to actually touch the tissue to work. Now, while we're talking about medications, we really need to address the ultimate contraindication in veterinary ophthalmology.
The rule that saves eyes.
Yes. Never, under any circumstances, use a topical corticosteroid if a corneal ulceration is present.
Or even if the patient is at high risk for one.
Exactly, because steroids suppress the local immune response and severely inhibit epithelial healing.
So if you put a steroid drop onto an existing corneal ulcer, you trigger what we call a melting ulcer.
Right. The tissue rapidly degrades, the ulcer deepens into the stroma, and the entire globe of the eye could potentially rupture.
It is catastrophic. You also avoid steroids if you have a known or suspected infectious conjunctivitis.
Because you're basically just turning off the local immune system and letting the pathogen multiply unchecked.
You must monitor any patient treated with topical corticosteroids. And if signs of corneal ulceration like sudden intense pain or squinting occur, the owner must discontinue the agent immediately.
Respect the green dye. If the fluorescein stain sticks to the cornea, steroids go straight in the trash.
Simple as that. So let's look at some safer nursing hacks, specifically for those dogs with allergic or follicular conjunctivitis. There's this brilliant environmental management strategy in the text.
Ah, the barrier and flush method.
Yes.
It's highly effective for atopic dogs. You instruct the client to apply a viscous artificial tear gel to both eyes before the dog goes out for a walk or runs in the yard.
So this gel creates a thick physical barrier over the conjunctiva.
Exactly. It essentially catches the pollen, dust, and antigens before they can physically touch and irritate the mucous membrane.
That is so smart.
Right. Then, the moment the dog returns indoors, the client flushes the ocular surface with a sterile eye wash to wash away all the trapped allergens.
It's a completely non-pharmacological way to prevent the allergic cascade from even starting.
But of course, if the barrier method isn't enough, you have to step up to targeted medical options.
Right. For those allergic cases, if there are no ulcers, you can use antihistamine eye drops, like ketotifen.
Or topical corticosteroids like dexamethasone, usually every 8 to 12 hours.
And for the German Shepherds dealing with that chronic lymphocytic plasmacytic conjunctivitis, the approach is a bit different.
Yeah, you often start with 0.1% dexamethasone every 8 hours to forcefully knock down the acute inflammation, but you immediately begin tapering to the lowest effective dose.
Because the ultimate long-term goal is to transition the dog to cyclosporine, right? Either a 0.2% ointment or a 1 to 2% compounded solution.
Exactly, because cyclosporine acts as a targeted immunomodulator rather than a blanket immunosuppressant like steroids.
So it manages the autoimmune response much more safely over the dog's lifespan without the constant risk of melting ulcers.
Exactly. Now, we talked about the viral alphabet soup earlier. What if the diagnostics point to a severe canine herpes virus 1 infection?
Ugh, the antiviral arsenal is highly specific and, frankly, exhausting for the client.
It really is. You can prescribe a 0.5% cidofovir solution, which is applied topically every 12 hours.
That's not too bad.
No, but if you're using a 1% trifluridine solution or a 0.1% adaxuridine solution, the protocol requires topical application every 4 hours.
Every 4 hours, day and night.
Yep.
That is an unbelievable burden to place on an owner.
It really brings the whole diagnostic gauntlet into focus, doesn't it? You cannot put an owner through a round-the-clock dosing schedule unless you are absolutely certain of the viral pathogen.
Definitely not. But even with perfect compliance, there are times when drops and gels just fail. When do we look at surgical intervention?
Surgery is indicated when the anatomy itself is the underlying driver or when the tissue is too profoundly altered to respond to medical management.
Like in severe follicular conjunctivitis.
Exactly. If those hyperplastic lymphoid follicles on the third eyelid are massively enlarged and unresponsive to topical steroids, you perform a follicle debridement.
So you mechanically scrape away the inflamed tissue to basically reset the surface.
Right. And if the issue is adnexal disease, like the entropion or ectopic cilia we mentioned, you have to cut.
You physically reconstruct the eyelid to stop the fur from dragging across the cornea.
And once you cure the frictional irritation, the secondary conjunctivitis resolves on its own.
And of course, for conjunctival neoplasia tumors on the tissue, the treatment may range from local excision to enucleation.
Which is the complete surgical removal of the eyeball.
Or even exenteration, where you remove the eye and all the surrounding orbital contents.
Yeah, it can get pretty drastic.
Well, that brings us to the end of our deep dive. Let's recap the vet student toolkit we've built today.
Sounds good.
First, remember the puddle and the roof. Always suspect a secondary cause, like KCS or an anatomical abnormality, before you ever assume a dog has primary bacterial conjunctivitis.
Second, religiously follow your diagnostic order of operations. The Schirmer tear test must happen before a single drop of liquid touches that eye.
Third, meticulously educate your clients. Solutions before ointments, wait 5 minutes, and clean the discharge first.
And lastly, fiercely protect the cornea. Do not reach for the topical corticosteroids if a corneal ulcer is present or even suspected.
Before we wrap, I want to leave you with something to mull over that kind of pushes beyond these standard textbook treatments.
Oh, I like where this is going.
We spend so much of our time in veterinary ophthalmology trying to basically carpet bomb the eye. We use broad-spectrum antibiotics to kill bacteria or powerful steroids to violently suppress the immune system.
True.
But as we begin to understand more about the ocular microbiome, the natural, healthy ecosystem of bacteria that lives on a healthy canine eye, it really raises a question about the future of treating chronic conjunctivitis.
It changes the paradigm entirely.
Exactly. Will the future of treating these recurrent secondary infections look less like dropping harsh chemicals onto the cornea and more like prescribing targeted ocular probiotics?
Instead of destroying everything on the surface, maybe the next great leap in veterinary medicine is simply learning how to rebuild the tear film's natural microscopic defenses.
Something to think about the next time you see a bright red eye walking into your clinic. Happy studying, and we'll see you on the clinic floor.